Imagine you're sitting in a chair and you decide, okay, time to stand up. It feels instantaneous, right? You think it and your body just does it. But for millions of people with Parkinson's disease, that simple translation from thought to action, that's where the signal just dies.
It's a disconnect. And for decades, we've treated Parkinson's as a sort of mechanical failure.
Exactly. Your hand shakes. Okay, that's a broken wire in the hand circuit. You shuffle your feet.
Must be a foot circuit problem.
Right. We've been obsessed with the effectors, the parts of the body that just aren't listening.
It's the intuitive approach, isn't it? I mean, if a light bulb flickers, you check the wiring going straight to that bulb.
Yeah, you don't check the breaker box for the whole house.
Not right away, no.
But today, we're taking a deep dive into a paper that suggests we've been looking at the wrong wiring diagram for, well, over 100 years. We're looking at a landmark study published in Nature, February 2026.
Titled Parkinson's Disease as a Somato-Cognitive Action Network Disorder.
And this isn't just, a tweak to the old model. This is a complete teardown.
Oh, it really is. The researchers, Jiangsun Ren and a massive team, have effectively dismantled the idea that Parkinson's is a disorder of specific body parts.
Instead, they're arguing it's a system-wide failure, a failure of a network they call the SCAN.
The Somato-Cognitive Action Network.
And for everyone listening, I want you to buckle up because we are going to go through this paper pretty much line by line. We are not skipping the hard stuff today.
No, we're going to unpack the anatomy, the specific glitch in the wiring.
And the clinical trials that prove this isn't just a theory. It's actually changing how we treat patients right now.
And just to set the scale here, this isn't some small pilot study. We're looking at a data set of 863 participants.
Wow.
Yeah. They used multimodal MRI, deep brain stimulation data, ultrasound. It's incredibly dense.
So let's start with the geography. To understand the SCAN, we kind of have to unlearn the brain map we were all taught in biology class. Remember the homunculus?
The little man, yeah.
That distorted little man draped over the top of the brain.
The Penfield homunculus, right. Since the 1930s, we believe the primary motor cortex, that strip of brain that controls movement, was a continuous, unbroken line.
You had the foot area next to the leg, next to the trunk.
A nice orderly progression, like bricks laid end to end.
But this paper confirms the map is wrong. Or at least it had these giant holes in it.
Exactly. The discovery here is that the motor map is, well, it's interrupted, interposed between those specific regions, sandwiched between the hand and the mouth, for example. Are these other sort of mysterious regions?
And they don't control a specific muscle.
No. They don't control a single muscle. They are the SCAN regions.
I love the analogy of bricks and mortar for this. The specific body parts, the hand area, the foot area, those are the bricks.
Right, they do one specific thing.
But the SCAN is the mortar holding them all together.
That works, but this mortar it's highly active. The brick, the hand region, knows how to contract a finger, but the SCAN controls action implementation.
Okay, what does that mean?
It handles the whole body's posture, your breathing, your heart rate, your arousal. It integrates your will to move with your body's actual physiological state.
So if I want to pick up this coffee cup, the brick moves my fingers.
Yep.
But the mortar, the SCAN, is what stabilizes my shoulder, regulates my breathing so I don't gasp, and anticipates the weight of the cup.
Precisely. It's the general manager. The bricks are just the employees on the factory floor.
And this is where the paper drops its first anatomical bombshell.
It really is. They wanted to know how this general manager talks to the deep brain. We know Parkinson's involves the basal ganglia, those structures deep down near the brainstem.
The famous problem areas. The substantia nigra, the subthalamic nucleus, where the dopamine dries up.
Correct. So the researchers used resting state functional connectivity to map the wiring. They asked a simple question. Who are these deep critical structures actually talking to?
And you'd think, common sense says they should be talking to the hand region. If Parkinson's makes my hand shake.
The deep brain should be wired to the hand region, right? But it's not. The study found that these deep structures, the substantia nigra, the putamen, the globus pallidus, are selectively connected to the SCAN regions in the cortex.
Selectively.
They are barely on speaking terms with the hand or foot regions. They're almost exclusively on the phone with the general manager.
That completely flips the script. It means the basal ganglia loop, the very circuit that degrades in Parkinson's, is actually a SCAN circuit.
Which leads to the fundamental redefinition of the disease in this paper. Parkinson's is not an effector disorder.
It's a disorder of the Somato-Cognitive Action Network. The shaking hand is just a downstream consequence.
It's the symptom of the general manager having a breakdown.
Okay, before we get into how it breaks down, let's do a quick recap just to lock this new anatomy in.
Good idea.
If you're taking notes, here are the 3 big takeaways so far.
Okay, point 1. We are redefining Parkinson's. It's not a disorder of specific muscles, it's a disorder of the scan.
Point 2. Anatomically, these scan regions sit between the specific motor regions for the hand, mouth, and foot. They are the mortar between the bricks.
And point 3. The critical deep brain structures involved in Parkinson's, they connect primarily to the scan, not to the individual muscle controllers.
So, listener, ask yourself this. If the wiring from the deep brain connects to the general manager, what happens when that connection goes haywire? Does the manager stop giving orders?
Or does he start screaming?
Hold that thought, because we're about to look at the glitch.
This is where we get into the mechanism of the disease itself. So the researchers compared 65 Parkinson's patients to 60 healthy controls.
Okay.
They wanted to see what that connection between the deep brain and the scan actually looked like in a sick brain.
Now, usually when we think of neurodegenerative disease, we think of loss, atrophy, disconnection.
Like a wire's been cut. You'd expect the signal to be weak, right?
Yeah, that's what I'd assume.
But that is not what they found. In the Parkinson's patients, the connection between the scan and the subcortex, it was significantly elevated. It was too strong.
Too strong. So it's not a cut wire, it's a short circuit.
It's hyperconnectivity. That is the key term here. Think of it like a feedback loop where the gain is just cranked up to maximum. It's screeching. The paper even describes it as a winner-takes-all scenario. In the Parkinson's brain, the scan territory actually expands inside those deep brain nodes, pushing out other networks. It just takes over.
So the general manager isn't asleep at the wheel. He's screaming into a megaphone, drowning out everybody else.
And this screaming disrupts everything, but they had to be sure this wasn't just a generic,
It's a movement disorder thing.
Exactly. So they looked at patients with essential tremor, dystonia, and ALS.
What did they find?
None of them had this. This scan hyperconnectivity was completely absent in those other disorders.
So it's a specific biomarker for Parkinson's disease.
It appears to be, yeah, which is huge for diagnosis.
But does it explain the symptoms? Because Parkinson's is so weird. It's not just shaking, it's anxiety, it's sleep problems, it's apathy.
And that's why the scan model fits so perfectly. Remember, the scan controls arousal and autonomic functions, not just movement. It's somato-cognitive.
Right, the mind-body connection.
Exactly. And the researchers found that the degree of this hyperconnectivity, how loud the screaming was, correlated perfectly with the severity of the symptoms.
So the louder the scream from that circuit, the worse the symptoms get.
Precisely. And not just motor scores. We're talking about anxiety scores, depression scores, and even cognitive decline. Because the manager handles arousal and anxiety, when that circuit is screaming, you get anxiety and sleep issues right along with the tremor.
It's all the same network malfunction.
Right. It unifies the motor and non-motor symptoms under one single umbrella.
Okay, so we have a target, the scan. We have a mechanism, hyperconnectivity. But how do we know this is real? How do you validate it?
This is where the paper turns to the treatments we already use, like Deep Brain Stimulation or DBS.
This is the surgical treatment where they implant electrodes deep in the brain.
Yeah, usually in the STN or GPI. And it works, but surgeons have always been sort of hunting for the sweet spot. If you miss by just a millimeter, it doesn't work as well.
So they analyze these sweet spots.
They analyzed 342 of them, and the results were just incredibly consistent. The most effective electrode locations, the ones that gave patients their lives back, were the ones most strongly connected to the scan.
So the surgeons have been targeting this scan wiring all along without even realizing it.
Unknowingly, yes. And they went further. They used something called ECOG placing sensors on the brain's surface while stimulating the STN deep inside.
And they saw a spark.
A physiological response, yeah.
Wow.
When they stimulated the deep target, the strongest electrical potential, the P1 amplitude specifically, it popped up in the scan regions of the cortex.
Not in the hand or foot regions.
Not in the hand or foot regions.
That is physical proof of the wiring. You ring the doorbell in the basement, and the light turns on in the scan room upstairs.
It is. And it's not just electricity. They also looked at medication. We know levodopa is the gold standard drug. When they scanned patients after taking levodopa, the MRI showed that the drug reduced the scan subcortical hyperconnectivity.
So successful treatment equals turning down the volume on that screeching connection.
That's the takeaway. Whether it's with electricity or with drugs, the goal is to dampen that scan connection.
Okay, let's pause for a second recap. This is the mechanism block.
Right. Here's what we've established. Point 1. Parkinson's brains suffer from hyperconnectivity, an overactive screaming communication loop between the deep brain and the scan.
Point 2. This glitch is unique to Parkinson's. You don't see it in ALS or essential tremor.
Point 3. Effective treatments like DBS and levodopa work by dampening this overconnection.
And finally, point 4. The surgical sweet spot is exactly where the electrode hits the scan wiring. So, listener, here is the million-dollar question. If we know the scan is the culprit, and we know a big part of it sits on the surface of the brain, do we have to drill deep into the brain to fix it?
Or can we fix it from the outside? That's the question that led to the most exciting part of this paper, the clinical trial.
Okay, this wasn't just observation. They actually tried a new treatment. They used TMS, Transcranial Magnetic Stimulation.
Basically, using a powerful magnet outside the skull to stimulate the brain non-invasively.
And they set up a randomized controlled trial, 36 patients.
Split them into 2 groups. Group A got magnetic stimulation targeting the traditional effector regions, the hand or foot area, the old way.
And Group B
got stimulation targeting the scan regions.
And this was double-blinded, right? Neither the patients nor the doctors knew who was getting which target.
Correct. They did this for 2 weeks. What happened? Well, the results were dramatic.
I'm guessing both groups got a little better placebo effect and all that.
A little, yes, that's expected. But the scan group, they improved significantly more and significantly faster.
How much more are we talking about?
Targeting the scan essentially doubled the efficacy compared to targeting the motor regions.
Doubled it.
Doubled it. And we saw it across the board: slowness of movement, rigidity, tremor, and even those axial symptoms like posture. They all responded better to the scan target.
Just by moving the magnet a few centimeters to hit the mortar instead of the brick.
And the post-treatment scans confirmed the mechanism. The patients who got the scan stimulation showed a physical reduction in that deep brain hyperconnectivity.
And the other group?
The patients who got the old-school motor stimulation, their symptoms might have improved a tiny bit, but the network glitch, that hyperconnectivity, was still there. It was unchanged.
That is the wow factor for me.
Yeah.
You didn't just mask the symptom. You actually fixed the underlying network glitch.
Exactly. It suggests that by targeting the scan, we're treating the root of the network dysfunction.
And the paper didn't just stop at magnets, right? They also looked at ultrasound.
MR-guided focused ultrasound. It's a non-invasive way to basically burn a tiny lesion in the thalamus to stop tremor. It's getting very popular.
It followed the pattern.
Same pattern. They looked at patient outcomes and found that the closer the lesion was to the scan sweet spot in the thalamus, the better the symptom relief was.
It's just so consistent. Surgery, meds, magnets, ultrasound. If you hit the scan, the patient gets better.
Which leads the authors to propose a comprehensive toolkit for the future. We're moving away from a one-size-fits-all approach.
So what does that toolkit look like?
It's a kind of hierarchy of circuit-based neuromodulation. For early stage or milder symptoms, maybe you use non-invasive TMS.
Okay.
For intermediate cases, maybe low-intensity ultrasound. For the most severe cases, you still go to the invasive DBS, but now you guide the surgeon specifically to the patient's scan node.
And they mentioned something about epidural strips. What was that?
Yeah, so implanting thin electrode strips right on the surface of the brain. It's much less invasive than digging deep into the brainstem, but it could offer constant stimulation to those sand surface nodes.
It opens up a middle ground between, wearing a magnet and full-on brain surgery.
Exactly.
We should probably briefly mention the beta band synchronization for the real neuro nerds listening.
Oh, briefly, yes. In Parkinson's, the brain waves can get stuck in this beta band rhythm about 13 to 35 hertz. It's like a status quo signal that locks the muscles up.
And this hyperconnectivity is related to that.
It's very likely they're two sides of the same coin. The hyperconnectivity we've been discussing probably is that beta rhythm, and breaking that rhythm is what allows movement to happen again.
Amazing. Okay, let's do our final recap before we send everyone off.
Let's sum up the clinical breakthrough. Point 1. Non-invasive TMS targeting the scan is twice as effective as the traditional method.
Point 2. Focused ultrasound also works best when it hits the scan nodes deep in the brain.
And point 3. We are looking at a future toolkit where treatments are personalized based on a patient-specific scan map, ranging from external magnets to deep implants.
It really feels like we are on the edge of a new era. We used to look at a shaking hand and try to stop the hand.
Right.
Now we know to look for the general manager in the brain and just calm him down.
That's the grand synthesis here. We have to stop calling Parkinson's just a movement disorder The authors, and I completely agree, say it is a Somato-Cognitive Action Network disorder.
It's a failure of the system that integrates mind, body, and will.
That's it.
And for anyone listening who has Parkinson's or loves someone who does, this changes the whole narrative. The brain fog, the anxiety, the trouble initiating movement. It's not all in your head, and it's not separate from the tremor.
No, it is all part of the same network overload. And it offers real hope. Because the scan is on the surface of the brain, it's accessible. We might see treatments in the next few years that are non-invasive, precise, and way more effective than what we have today.
I want to leave you, our listener, with one final thought to mull over. We talked about how this hyperconnectivity, this screaming feedback loop, is the signature of the disease.
And it's specific to Parkinson's.
So if Parkinson's is actually a connectivity problem in a specific network, could we eventually catch it early? I mean, really early.
Before the symptoms start.
Exactly. Could we scan a 40-year-old, see that the general manager is just starting to raise his voice, see the hyperconnectivity starting years before the hand ever begins to shake? And could we use these magnets to turn the volume down before the first symptom ever appears?
Preventative circuit maintenance. That is a fascinating possibility.
Thanks for taking the deep dive with us. Keep your networks connected.